Welcome back to the deep dive. Today we are heading into a scenario that feels, less like a classroom and more like a courtroom drama.
Or maybe a bomb disposal unit.
Right. We're looking at the super high-stakes world of postgraduate medical exams, specifically the ENT, that's ear, nose, and throat clinical exam.
It really is high drama. I mean, you have a candidate probably sweating in front of a panel of senior professors.
And they have to prove not just that they know the facts, but that they can think like a surgeon, under immense pressure.
Exactly.
And our source material today is basically the cheat sheet for what they call professional authenticity in these exams. We're zeroing in on a really heavy case, oral squamous cell carcinoma.
Mouth cancer.
Mouth cancer. But the mission here for us isn't really to teach surgery, it's to look at this fascinating transition, how a doctor goes from being just a casual history taker to what the sources call a surgical strategist.
And that phrase, surgical strategist, that's the anchor for everything. It's not just about the words you use. It's a completely different mindset.
How so?
Well, a casual doctor, they're just gathering data. It's like a clerk making a list. But a strategist is gathering evidence to build a very specific battle plan.
The sources kept mentioning you're not just asking questions to be polite, you're building a TNM profile. I saw that all over the notes. What exactly is TNM?
It stands for tumor, nodes, and metastasis. Think of it like a coordinate system for the cancer.
Okay.
T is the tumor itself, its size, how far it's gone. N is for nodes, has it traveled to the lymph nodes in the neck. And M is metastasis, has it spread somewhere else, like the lungs.
So every single question has to help fill in that TN or M part of the puzzle.
If it doesn't, you're just wasting time.
So it's like a detective who stops asking, so how was your day? And starts asking, where were you at 9:00 p.m.? Because every detail could change the entire verdict.
That is a perfect analogy. And to see it in action, we have a specific patient file to work with. A 50-year-old woman from Karachi, widowed, wheelchair-bound, with a growth in her cheek.
Okay, let's unpack this. The guidelines say it starts right at the beginning with identity and presentation. Now, I gotta be honest, this seems like the boring part. Name, age, address.
The paperwork.
Yeah, why do we need to strategize about an address?
See, that's the trap. The casual way is just, what's your name? And you move on. But for a specialist, those are risk calculations. The source material points to 4 things: age, occupation, residence, and socioeconomic status.
Okay, let's stick with residence for a second.
Yeah.
Why does it matter where she lives? Is cancer different in Karachi versus somewhere else?
The biology is the same, but the cause might be different. The guidelines talk about cancer belts.
Cancer belts, that sounds ominous.
It is. These are specific geographic areas where the incidence of certain cancers is way higher. Maybe it's because of industry.
Like, are they near textile mills, dye workers, that kind of thing?
Exactly. Dye workers are exposed to known carcinogens. If you don't ask about her occupation or where she lives, you miss the why. If she comes from a known cancer belt, your suspicion just hits the roof before she even says a word.
You're profiling the enemy.
You are. And you're also establishing what the sources call the patient's language. This is another subtle test.
What do you mean?
A rookie doctor might just write down growth for 8 months. It's short, it's efficient,
Sounds fine to me.
but it's clinically hollow. The right way is to record it as painful progressive growth inside the left cheek.
I see the difference now. Progressive and painful aren't just descriptions.
No, they are behavioral traits of the tumor. Progressive tells me it's aggressive. Painful tells me there's probably nerve involvement. You have to capture the character of the monster, not just that it's there.
Let's get into the case study then, because there's a detail in here that it floored me. So this 50-year-old woman comes in, and the source calls this the onset trap. The patient tells the doctor, I noticed a lump, so I cut it with a clipper.
Yeah. It's a visceral moment.
I mean, hold on. She took a pair of household clippers to the inside of her own mouth. My first reaction would be, oh my God, why did you do that?
And that's a very human reaction. It's also the casual reaction. You get stuck on the shock of the event,
But the surgical strategist has to do what?
suppress that shock, and pivot immediately.
Pivot to what was there before the clipper.
Exactly. She cut it because something was bothering her. The real question is, before you cut it, was there a white patch? That's leukoplakia. Or maybe a red patch. That's erythroplakia.
You're looking for the prequel to the story.
You are looking for the pathogenesis. Was this a dicking time bomb, a pre-malignant lesion that she just tried to remove herself? The clipper is distraction. The history of that patch. That's the diagnosis.
Wow, that takes some serious discipline. Okay, let's talk about quantifying symptoms. The notes mention checking for trismus, which is basically lockjaw.
Right, how well the patient can open their mouth.
The rookie asks, is it hard to open your mouth? Seems perfectly reasonable. But the expert asks, how many fingers can you fit between your teeth?
Yes.
Really, I mean, we have MRI machines, CT scans, and the expert move is to use fingers. It sounds a bit medieval.
It does sound primitive, I'll give you that. But it's actually an incredibly sophisticated functional test. You're not just measuring a gap, you're testing the pterygoid muscles.
Pterygoid muscles.
They're deep in the jaw, they control opening. If the patient can only fit 1 finger, it tells you those muscles are basically frozen, likely because the cancer has invaded them. It's in what we call the masticator space.
And what does that mean for our TNM grid?
It immediately pushes the cancer to stage T4. It means the tumor is deep, it's nasty, and surgery becomes incredibly difficult. And you get all that information just by counting fingers.
Okay, I take it back. That is efficient. What about pain? She mentions her ear hurts.
Oh, this is a classic ENT detective moment. The
Oh.
casual question is, does your ear hurt? Patient says yes. Doctor writes, ear pain. End of story.
But the strategist,
The strategist asks, do you have sharp shooting pain in the ear despite having normal hearing?
why the distinction about normal hearing?
Because if her hearing is fine, the problem isn't in her ear, it's a crossed wire. It's something called referred-atalgia.
So the ear is perfectly healthy, but the brain thinks it's on fire.
Precisely. You have this nerve, the auriculotemporal nerve. It runs like a highway from your jaw right up past your ear.
Okay, I'm picturing the highway.
Well, the cancer in her cheek is hijacking that highway. It invades the nerve in the jaw, and the pain signal travels up the line and basically rings the doorbell in the ear.
That's terrifying. The cancer is using the body's own wiring against it.
It is. And that specific pain tells the surgeon the tumor is paraneural, likes to travel along nerves. That completely changes how you do the surgery.
This leads us into what the notes call silent indicators, things that signal disaster under the surface. Let's talk about bones and nodes.
Right.
The source mentions a dental connection, and the expert questions are any of your teeth loose? Or is your chin numb?
We're not looking for cavities here. We're looking for mandibular invasion. Has the cancer gotten into the jawbone?
And how does a loose tooth tell you that?
Think of a tooth like a fence post set in the ground. If the bone is being eaten away by the cancer, the post gets wobbled.
And the numb chin?
That's the nerve again. The inferior alolar nerve runs inside the jawbone. If the chin goes numb, it means the cancer is literally inside the tunnel of the bone, strangling that nerve.
That's T4A, instantly.
Immediately. And then there's the neck. A fatal mistake is to only look at the mouth, because that's where the obvious problem is.
But the nodal status is vital.
The neck is the escape route. If there's a hard, painless lump in the neck, it means the cancer is spread to the lymph nodes. Survival rates drop by 50%.
50.
At least. If you don't ask about neck lumps, you might do a perfect surgery on the mouth and leave the real killer behind.
Let's pivot to past history. The patient says she had light therapy before. To me, that sounds gentle, like a laser facial or something.
And that ambiguity is the danger. Light therapy is often a colloquialism for radiation, but the expert has to dig deeper. Was it curative radiation or was it palliative?
What's the difference for the battle plan?
It's a huge difference. Curative means they tried to kill it with a high dose. If the cancer's back now, it's a recurrent case. And operating on radiated tissue is a nightmare. The flesh is woody, the blood supply is shot.
So it won't heal properly.
It just won't heal. Whereas palliative might have been a low dose just to stop some bleeding. The tissue might still be viable for surgery. You have to know what battle was fought before.
Okay, let's talk about habits. This patient uses Chilia betel nut.
A very, very common carcinogen in South Asia.
She's been using it for 15 years. Now, I'd assume the risk is just, 15 years is bad, but the expert brings up this terrifying math of carcinogens.
It's not just about duration. It's frequency plus contact time. And the key question is, do you keep the quid in your cheek while you're sleeping?
People sleep with it in their mouths.
They do. And think about what happens at night. Saliva production drops. So instead of washing the chemicals away, you are basically marinating the inside of your cheek in a concentrated carcinogen bath for 8 hours straight.
Marinating, that's a gruesome image.
But it's accurate. The risk just skyrockets. And then there's the cessation logic. A rookie asks, did you stop? Patient says yes. Great. But the strategist asks, when you stopped, did the growth slow down or did it speed up?
Why on earth would it speed up after stopping?
It's a massive red flag. It means the cancer is no longer just reacting to the irritant. It's acquired its own biological aggression. It's driving itself now.
It's become the poison.
Yeah, correct.
This brings us to social history, and I have to admit, I saw a note here that made me laugh out loud. The airy house question.
Chuckles. The classic area house.
The source says students are obsessed with asking, is your house well ventilated? I'm thinking, does the tumor need fresh air? Is it claustrophobic?
It's a reflex. It's drilled into them because of tuberculosis, which spreads in damp, closed rooms. So it becomes this muscle memory question. But for mouth cancer, it's completely irrelevant.
The examiner must be rolling their eyes.
Big time. But while the airy house is a joke, the actual living situation is deadly serious. Remember our patient. She's a widow in a wheelchair. And we are planning a surgery that involves a PMMC flap.
Pectoralis major myocutaneous flap.
Right. We are going to take her main chest muscle, tunnel it under her skin, and sew it into her face to patch the hole.
That sounds unbelievably brutal.
It is a massive reconstruction. She will have wounds on her chest, neck, and face. So the strategist doesn't ask about windows. They ask, who cooks your food? Do you use a gas stove or a wood fire?
Because if she's trying to cook over a smoky fire in a wheelchair with a fresh chest wound,
The flap fails. The reconstruction dies. Or worse, she just can't feed herself. Who's going to blend her food? This all ties into her Karnofsky performance status.
which is a score of how well she functions day to day.
Exactly. Can she dress herself? If her score is low, she might not be strong enough to survive the chemo or radiation that comes after the surgery.
So you're constantly balancing the cure against the cost to her life.
Always.
Okay, so we've grilled the patient, counted the fingers, mapped the nerves. Now I want to use that signposting technique the sources talk about. Expert speaker, I am now transitioning from the history and investigation to the management plan.
Chuckles. I see what you did there. Very smooth. And that's exactly what the examiners want to hear. You're telling me exactly where we're going.
So what's the plan? How do we fix this?
First, confirmation. Based on the history, it's 99% squamous cell carcinoma. But we need proof.
The workup.
Gold standard is a CECT, a contrast CT scan of the face and neck. We need to see those bones and nodes. If we can't get a CT, an OPG, that panoramic dental x-ray will do for a quick look.
And a biopsy, of course.
Essential. We need the grade. Is it well differentiated or poorly differentiated? That affects the radiation plan later.
And the surgery itself. It's not a solo mission, is it?
Never. It's an MDT decision, a multidisciplinary team. You, the surgeon, the radiation oncologist, the pathologist. For this woman, the plan would be aggressive. Wide, local excision of the tumor,
Taking it out with a safety margin.
plus a neck dissection to clear out all those lymph nodes, and then the PMMC flap to reconstruct the defect.
And probably radiation afterwards.
Very likely, especially if we find it was traveling along those nerves we identified in the history.
It's just amazing that the success of that massive 10-hour surgery hinges on the accuracy of the 10-minute chat you had at the very beginning.
That's the whole takeaway. If you miss the nerve pain, you might leave cancer behind. If you miss the social history, she might recover from surgery but fail at home. The history dictates the entire strategy.
And I really like that concept of signposting we used a second ago.
It's a huge pro tip. When a student says, I will now move from the history of the primary lesion to regional spread, they're signaling authority.
They're basically saying, I'm not lost, I have a map, and I'm driving.
Exactly. It shows you have that surgical mind. It's structured, logical, prioritized.
So what does this all mean for us? For the listener who hopefully isn't diagnosing mouth cancer tomorrow.
I think it comes down to that idea of quantified curiosity. We all ask questions every day, right?
Yep.
In business and relationships. But are we asking casual questions or are we asking strategic questions?
Don't just ask if the problem is bad, ask how many fingers wide the problem is.
Right. Don't just ask if the project is delayed. Ask if the delay is progressive or static. Don't just ask if your team is stressed. Ask about the infrastructure. Who is cooking their dinner? Who is supporting them?
I love that. Move from being a tourist in the conversation to being a strategist.
And here's a final thought for you to take away. We talked about how the patient tried to clip her own tumor, probably out of denial or desperation. How often in our own lives do we try to clip a problem with a quick fix instead of looking for the pathogenesis, the real root cause that started it all?
Are you treating the growth or are you treating the origin? That is a great challenge. Put down the clippers and start asking the real questions. Thanks for diving in with us today.
My pleasure as always.
See you on the next deep dive.